Dear colleagues, ladies and gentlemen, welcome. I'm Dr. Ashraf Amir. I'm a consultant in family medicine. Today we are tackling a silent crisis in our clinic. We often treat obesity as a matter of weight or appearance, but inside the body, much more dangerous processes are unfolding. One of the which is MASH, or a metabolic dysfunction associated steatohepatitis. Join us today to navigate this with Dr. David Macklin to explain why a liver is the ultimate victim of metabolic syndrome. In family medicine practice, we are the gatekeeper and we see patient long before see the other specialties. We often hear about fatty livers almost casually, like it's a normal part of aging, but what about its dangerous cousin, MASH? To simplify this for all of us, MASH is when a fatty liver is become angry and inflamed. Think of it as a wound that won't heal. Then how can the primary care physician in a very limited time, which is 15 minutes of consultation, can address the issue of MASH?
Thank you so much. It's a pleasure to be here. And it's also a pleasure to communicate to primary care physicians. My original role in medical practice is through primary care. My first degree was in psychology and neuroscience and then primary care, and now specialized in obesity medicine. I have worked exclusively in obesity medicine for 21 years.
That's amazing.
And what I've learned over 21 years, one of the key lessons that I've learned is to, when we address a disease, is really to get to the root of the disease.
Absolutely.
The primary importance in the health of a patient, I believe, is the relationship they have with their primary care physician. It is a unique relationship, unlike with a specialist. We can develop a relationship with our patients as primary care doctors.
Yes.
And communication between us and our patients is paramount and critical. And so today we talk about MASH. We talk about inflammation, excess adiposity in the liver. And so if we have a relationship with our patients, where is the best place to start?
Primary care.
Primary care. And in our
Absolutely.
conversation, where is the best place to start? We say at the beginning.
Yes.
So we are talking about excess. I am a co-author of the Canadian Clinical Practice Guidelines for the treatment of obesity, a now globally celebrated clinical practice guidelines for the treatment of obesity.
Okay.
And in our guidelines, we define obesity. And I'll start with obesity. We define obesity as excess adiposity or abnormal adiposity or ectopic adiposity, meaning fat being in a place where it shouldn't be, that is impairing health and quality of life. MASLD and MASH are great examples of ectopic adiposity, fat where it shouldn't be, impairing someone's health. But wait a second, shouldn't we start at the beginning? We should start with the question of how did the fat get there in the first place?
That's right.
Why is there, in this patient sitting across from me, why is there excess fat in their liver? And to answer that question, we begin with the disease of obesity. We define obesity not only as excess adiposity, that is impairing health, but we also talk about the root of how the fat got there in the first place. Did it come from outer space? Why is it sitting within the liver of our patient sitting across from us? You see, obesity is now understood to be a disease of appetite dysregulation. We ourselves communicate to our patients that we invite them to consider and ask if they would be surprised to know that 70% of someone's risk of struggling with excess weight and adiposity and obesity and extra weight in their liver, 70% of that risk is conferred genetically.
Okay.
They may be surprised to learn that the majority of the genes that predict for who will struggle with excess weight, those genes are in the brain. We inherit somewhere between 2,000 to 3,000 genes, all of different variants, that determine who will struggle with weight in their lifetime and who will not. By the way, I come to the Kingdom of Saudi Arabia for a very specific reason. I feel a moral obligation as an obesity specialist to come here because I know that in this country there is a higher than average genetic vulnerability to both obesity and MASH.
Yeah.
And so I invite patients to consider that their struggle is with
Yeah.
a real disease.
How about the epigenetics contribution to obesity when we talk about obesity in the kingdom
Yes.
of Saudi Arabia?
Yes. So the foundation of genetic vulnerability is then confounded with the principle of epigenetics. In other words, our environment impacting the expression of the genes that we have. Genes can be turned on or they can be turned off. And epigenetics speaks to the science of environmental elements that can turn on genes that increase our risk of struggling with weight.
Okay.
One of the most important environmental insults that drives the epigenetics of obesity in the Kingdom of Saudi Arabia, we call the obesogenic food environment.
Mm-hmm.
You see, the human brain was built to motivate us to do the work to get calories. Correct me if I'm wrong. I assume that today and yesterday, for the food that you ate, it did not involve in you any digging in the earth. Is that fair to say?
Yes,
Did you
absolutely.
climb a tree to get your food today?
No.
Did you cross a river? Did you climb a mountain?
Yeah, it was easy to get.
Easy.
Yeah.
And that's the problem. You see, with less work involved, our brains are built to motivate us to calories, to do the work to acquire calories, and now there is no work involved. From a genetic and epigenetic perspective, also the foods that we eat now are different. We call this the obesogenic food environment. Ultra-processed foods, ultra-available foods, ultra-portioned foods, foods filled with sugar, fat, and salt. And through associations of our old brain and the modern food environment, a conditioning starts to take place. It's a progressive disease. And so where do we start in our clinical practice guidelines, and where would I suggest every family doctor listening today start their consultation with a patient who they suspect may have MASH or obesity? Our guidelines say the place to start is to invite a patient to consider that their struggle with weight is not their fault. You see, people who struggle with weight, we have learned, and we wrote this into our first chapter in our guidelines. The first chapter, people start to believe that struggling with weight is their fault. They're not strong enough. They don't have enough willpower. They're not trying hard enough. And I mean this with great respect, sometimes the message that they receive comes from their primary care doctor.
Absolutely.
Try harder, diet more, exercise more. And they internalize bias and start to believe that their weight is their fault. So where we start a consultation with a patient living with MASH or obesity, we invite them to consider that their struggle is valid and real and genetic and brain-centered.
And they get stigmatized as well as by the community as well by being obese.
Yes.
So they will feel the stigma, being disfigured,
Yes.
and they are not looking, very slim and so.
Can you imagine a
Okay.
primary care doctor leaning in with a patient who lives with obesity and saying, "Can I invite you to consider something?" The science has changed. We now consider struggling with weight to be a real condition, brain-centered, genetically conferred, not your fault, and something for which treatment exists. We have 3 pillars to treatment for obesity. The pillars of treatment are behavioral therapy. This conversation is an example of behavioral therapy. Medical therapy. We have 2nd or 3rd generation medications that are extremely effective, and surgery as well. And so we invite patients to consider real disease, not your fault, and treatment exists. Are you interested in talking about this? The primary care physicians listening say, "Oh, obesity is too complex to treat." I'm here to suggest it isn't,
No.
and I'm going to suggest that the primary care office and the relationship you have with your patient is the ideal place to effectively treat obesity and MASH.
Thank you.